Hello. The sound in the room is fantastic.
Same for us. Thank you.
Yes, now we can hear.
Yeah, good. Thank you. Thank you.
Wow. Silvia.
Sì.
Prova a vedere se va.
Okay. Can you hear again?
Yes.
Yes, we can.
Okay. And can you see the slides and here everything is okay?
Hello.
Yes.
Yes.
Yes. Okay. Thank you. Sorry for the inconvenience. Well, talking about the methods of the study, I was talking about the sample composed for 218 adolescents between 8 and 12 years of age. The majority of their parents were married or living with a partner, and they were employed full-time. Most of them had a bachelor's degree or secondary education and vocational training. The majority of the children were born in Spain and reside primarily in the provinces of Alicante, Madrid, and Balearic Islands. Almost 18% of the children were receiving any kind of psychological treatment. Well, talking about the instruments that we use in this study, we asked for socio-demographic data of the children, like gender, age, psychological treatment, country, and province of residence, and also parents. The following children self-report measures were used. The first one was autoconcepto forma A, is the translation self-concept form 5. This questionnaire assesses 5 dimensions of self-concept, including academic, social, emotional, familial, and physical, with 6 items in each factor. A higher score indicates a better self-concept, except for the emotional dimension, where it is lower. The second instrument is the Short Mood and Feelings Questionnaire, validated in Spain by our team. In this measure, a higher scores indicates more children's depressive symptoms, with 13 items. The third instrument was the short version of the SPENS Children's Anxiety Scales, the SCAS C8. Using 8 items, higher scores indicated higher anxiety symptoms. And last, the Social Worries Questionnaire by Spence, in its Spanish version, validated also by our team, assessed situations that generate social anxiety, which is a construct not fully covered by the SCAS C8, and is composed by 14 items. And the study was disseminated through social media, including WhatsApp, Facebook, Twitter, and Instagram, using snowball sampling. Informed consent and sociodemographic data were completed by parents, while questionnaires were filled in by children. No financial incentives were offered to participants. Talking very briefly about the statistical analysis, we use the R project software in a version for Mac, and we use Spearman's correlations between the variables due to the absence of normality. We calculate and show in a correlation matrix, and after these correlations were interpreted following the Cohen criterion. Furthermore, a network analysis was performed with the Futterman-Regnol estimation based on the correlation matrix. Lines of the network were adjusted to the correlations direction, negative or positive, and size, small to big. Moreover, closeness, betweenness, and strength of each node in the network were estimated. Proceeding to the results of the study, we can show the Spearman's correlations matrix between the variables considered. Self-concept dimensions show moderate to high correlations between them, except for emotional self-concept, where these are weak. Moreover, higher academic, social, physical, and familial self-concept dimensions are related to lower internalizing problems, especially depression and social worries. A lower emotional self-concept is related to more internalizing problems, especially anxiety symptoms. Among internalizing problems, correlations are moderate to high, being the strongest relations between depression and anxiety, and the weakest between social worries and anxiety. The network analysis showed in figure 2 shows that all variables are connected with positive and negative correlations, positive in blue and negative in red, in a weaker or stronger way, the weaker thinner line and stronger in a thicker line. As some authors state, the collocation of a node in the network graph may be casual, so the information is provided by the network parameters shown in the figure 3. It appears that emotional self-concept is the closest variable to other nodes and is a good predictor of them, followed by physical self-concept, family self-concept, and anxiety. Emotional self-concept is also the most connected variable to others. Appears between two other variables more frequently. Regarding strength, depression appears to have the strongest association with the other nodes, indicating that it influences them highly. This work allows gaining the evidence of the relationship between internalizing problems and self-concept dimensions in children. First, the associations between different self-concept dimensions and depression are confirmed. As well with anxiety and especially social anxiety. The relation between these variables and self-concept could be explained by transdiagnostic factors also present in depression. Regarding network analysis and following previous literature, as Liu et al. In 2022, as depression shows the highest relationships with the structure, it becomes a key variable whose activation will be related globally to the activation of anxiety, social anxiety, and self-concept difficulties. However, the less closeness between it shows that despite its strong relationships, it is not intermediate nor highly close to the other nodes individually. Emotional self-concept stands out by being in the middle of the other nodes, so it appears to be essential in the activation in other nodes if other nodes are activated. Emotional self-concept is also a good predictor of other variables, as well as anxiety, familiar, and physical self-concept. Thus, the perceived skills to regulate anxiety and fear in children, as well as the depressive symptoms, are key variables in understanding and assessing the relationship of internalizing problems and self-concept difficulties in pre-adolescent ages. Despite the limitation in the sample size and the sampling method, this work enables to develop analysis, through network analysis, to identify relevant variables and their relationships in the assessment and treatment of children with internalizing problems. Future lines of research could include the addition of other constructs in order to understand from this approach the relationships in children. That is all. Thank you very much for your attention, and I'll be open if you have any questions. Thank you. You can also use my email address in the slide to contact if you need more clarification or any other contacts. Thank you.
I got a question.
Oh.
No, because it is interesting about social anxiety, and this is maybe there is some connection between the specific age of children and the stuff they have to face at school and etc. Yeah.
Yeah, it seems well, as within the network analysis, social anxiety is one of the key anxiety areas in which can affect all the areas of the functioning of the kid, like the mood or social functioning, adapting to school. So it's like the ability to communicate and to have more friends and to not to have fear of talking in front of others or start in a new social environment. It helps to many other areas. Thank you for your question.
Other question? I don't know if there are other questions from other side.
I can check.
Okay, the next one. Non so se possono altre domande, se ci sono altre cose, se non le mettiamo.
No question. No additional question.
Okay, thank you. Thank you. interessato troppo anche. The next presentation, it is about prep and pray, okay? Right. So, we can share this screen. That main screen, so it is okay, so. Okay. Yes, sorry.
Good morning, everyone. I am Maria Mirandi and I am a PhD student at the University of Perugia. My talk focused on pretend play in the assessment of children with specific learning disorder. It is important, the developmental age assessment, because the psychological assessment is a process that leads to a description, diagnosis, and explanation of child behavior. Assessment in particularly complicated with children because the developmental change and a different people involved. Play is among the most used tools in the assessment of children. As shown by several scientific studies, pretend play is one of children's favorite means of expression, helps children connect with the internal world and the world around them, promotes effective and cognitive development, and correlates to psychological adjustment. But why is pretend play important in assessment? In the assessment process, pretend play is considered an indispensable tool for understanding the children's cognitive and effective functioning, and it is a powerful tool for the clinician as it allows children to express themes and experience. Pretend play is an authentic assessment to identify their strengths and difficulties, and so it is necessary to have tools for assessing the pretend play. The most widely used tool for assessment of the pretend play is the affect play scale. However, there are few studies on clinical samples, and there are not current studies on pretend play in children with specific learning disorders. Learning disorders are neurodevelopmental disorders characterized by significant difficulties in the acquisition of one or more of the basic school skills, for example, reading, writing, and calculation. Children with specific learning disorder have intellectual abilities within normal limits, the absence of sensory deficits, the absence of psychopathological serious disorders, and normal educational opportunities. In children with learning disorder, the emotional dimensions seems to be also impaired because of the difficulties encountered in achieving goals that seems simple to others. So, the aim in this study were to investigate the cognitive and affective abilities of children with a specific learning disorder, comparing them with a community-based samples, and to outline the functioning profiling of children with specific learning disorders. But what do we expect? Given the sense of inadequacy that children with a learning disorder experience in relation to school demands, and the expectation of others, and the consequences of the disorder at cognitive and affective abilities, we have outside a different cognitive and affective abilities in children with a specific learning disorder than children in a community-based sample. The participants in this study were 60 Italian children, and half of whom the participants were children with a diagnosis, and the second half is children in a community-based sample. The age range was 6 to 10 years, and more than half of the participants were male. Children with a specific learning disorder were recruited for specialized center in the region of Umbria and Marche, and a preliminary analysis found no significant differences between the two groups by age, while sex difference emerged. In particular, there was a difference in a group of children with a specific learning disorder because the number of the male was more than a female. The instrument used in this study was Effect Play preschool version, and these tools consist in specific materials, such as we can see in this picture, in the slide. There are stuffed animals, or a plastic animal, a toy car, a ball, and a cups. And children are asked to play aloud and to assess the positive and negative effect themes and the cognitive themes. The effect themes consist into two dimensions, negative dimension and positive dimension. The negative abilities were aggressiveness, oral aggression, anality, anxiety, frustration, and sadness. And positive themes consist affection, competition, happiness, orality, and sexuality. While a cognitive themes consist in 4 dimensions: story, construct, organization, elaboration, imagination, and comfort. Organization is a story construction and planning. Elaboration is a personalization of the play. Imagination assesses the originality of the play, and the comfort is a degree of confidence and enjoyment. This study is a cross-sectional study, and the data analysis used in this study is an independent sample t-test in order to compare the children with a specific learning disorder with the children in a community-based sample. The result, as we can see in this graph, confirm the hypothesis because the children with a specific learning disorder express more negative themes than the children within a community-based sample, but the positive themes was lower in a children with a specific learning disorder than a children in a community-based sample. While in the cognitive abilities, there aren't differences because the abilities assessed in this study is a specific cognitive abilities, such as organization, elaboration, imagination, and comfort. And this is ability there aren't specific in the children with a specific disorder. So, although most studies have focused more on cognitive difficulties, this study and this result show a greater expression of emotional difficulties than cognitive difficulties in children with a specific learning disorder. The prevalence of negative affect themes highlights the sense of inadequacies that children with a specific learning disorder experience in relation to school demands and the expectation of others. In conclusion, it is therefore important to investigate the assessment, the effective abilities of children with learning disorder to sustain and promote their emotional development. This study has important limits because the number of the participants are few, because only 60 Italian children consist in the sample, and only 30 children are a diagnosis. The sample, there aren't homogeneous. It is a cross-sectional study and sample not representative of the entire population. For this reason, future study should be expanding the sample and investigate the cognitive and the affective abilities with the affect play scale in different clinical samples. For example, in children with internalizing and externalizing the disorder and the medical disorders. For example, children with anxiety disorder or children in optional defined disorder. I have concluded. I thank you for your attention, and I put my mail for more questions. Thank you.
That's something. May I ask you more about the cognitive results? What you think about that?
The cognitive, yeah. Why there aren't?
Because you underline the negative aspect, but not enough to be about cognitive results.
Yes, there are a difference between. Yes, there were differences between affective abilities and positive abilities, but there are not difference in cognitive abilities because the variable assessed in this study is a specific variable: organization, elaboration, imagination, and comfort, and this cognitive abilities is different the ability in the children with a specific learning disorder, because in these children the difficulties are in the writing, reading, and calculation, but not in the organization or in the elaboration of the story.
The person? No. Okay, thank you. We are going next to stage. And Professor Ochil will talk about.
And your presentation of this one.
I'm sorry, you needed to share.
No, this. I'm share the main.
Okay, okay.
Not for the.
Okay.
No, thank you.
Okay, so good afternoon. Thank you so much to the organizing committee of this conference for providing me with the opportunity to present this study titled Bibliotherapy to Overcome Fear of the Dark in Children, a pilot study, a study developed in collaboration with my research team based in Spain. To introduce the study, I'd like to highlight that the fear of the dark is a common problem in children, affecting 1 in every 3 children. It tends to impact younger children the most, typically between 3 and 6 years old, and it used to decrease and disappear with age in most of cases. But however, in some children, this fear persists and has negative effects on both the children and the family. In these cases, the fear episodes are frequent and intense, having consequences. One significant consequence of the fear of the dark in children is the impact on academic performance. Children who don't sleep well due to this fear can be tired at school and can't engage in the classroom activities. Additionally, they may have social difficulties such as avoiding sleeping at their friends' houses or participating in school trips, as they need to have the light on when they sleep. Besides, in some cases, parents may have conflict between them. They have different opinions about the problem and its solution. The origins of fear of the dark can be explained by various factors. One factor is the connection between darkness and nightmares, which makes children want to avoid sleeping without any light. Also, modeling may contribute to fear of dark when children observe other family members like brothers, sisters, crying or expressing fear in dark situations. For example, when the power suddenly goes out at home. Negative information about darkness also plays a role, as in stories, movies, or tales. Bad things or bad characters like monsters, witches, and ghosts tends to appear at night. Treatment options for this problem often include cognitive and behavioral techniques like gradual exposure, modeling, and positive reinforcement. The objective always is to help children confront their fear and realize that nothing bad can happen while they sleep. However, since children may refuse to engage in these treatments, especially exposure, alternative treatments like bibliotherapy and play therapy may be a good option. Bibliotherapy has advantages for both children and their families because by including characters in stories as role models for coping with dark situations, it provides a positive way to teach children how to deal with their fears. Moreover, families who have difficulty attending therapy sessions may benefit from bibliotherapy because they can follow the therapy at home as therapists reading a book and play with her kids. So the main objective of this study was to assess the efficacy of a combination approach including bibliotherapy and games based on cognitive and behavioral techniques to reduce nighttime fears in a sample of Spanish children between 4 and 8 years of age who were experiencing fear of the dark. We had a total of 20 participants in our study, all Spanish children between 4 and 8 years, half of them girls. Children were selected to be included in the study. They were between 4 and 8 and living in the province of Alicante in the southeast of Spain. Also, they needed to reach a score of 36 or higher on a scale assessing the nighttime fears and meet the diagnostic criteria for a specific phobia of darkness. The 20 participants were assigned to an intervention group or a waiting list control group, allowing us to compare the fear of dark before and after the treatment period. Parents of both groups completed some questionnaires before and after the therapy. First, a diagnostic interview based on DSM-5 criteria. So parents answered 7 questions to determine if their children had symptoms of a specific phobia related to darkness. They had to answer yes, indicating that the criterion was met, or no, if the criterion was not met. Also, the nighttime fear scale, the parent version, we use this scale that consists of 21 items to evaluate the level of fear at night. So higher scores indicate higher intensity of fear. Also, families were provided with a nightly record document to complete, reporting the number of minutes the children needed to go to bed and to fall asleep, among other information. And we also collected qualitative data through contacts with family, asking about progress that the children made and difficulties during the intervention. These interviews were conducted through telephone calls. So regarding the procedure, parents applied intervention for 4 weeks. First, we organized a meeting with the families, providing them with information about the problem and giving them instructions to apply the treatment at home. And the treatment consists of reading a story and play some games. It is a story, an American study that we translated and adapted into Spanish. Parents received the book for reading with their children. The book was titled Uncle Life Would Turn on the Light, and also a guide with written instructions for them to play with their kids. The book tells the story of a boy named Miguel, who is afraid of the dark. So to overcome his fear, Miguel goes to see Uncle Lightfoot, a character who teaches Miguel many games aimed at developing new skills to confront his fears. Miguel, along with Uncle Lightfoot, his family and friends, will feel more comfortable in the dark as he follows the guidance of Uncle Lightfoot. The story includes 22 chapters that children have to read with their parents during the week, and some games addressing common fears such as darkness, nightmares, noises, monsters, or shadows. The games give the children to learn coping skills to gradually expose to darkness, And games are a fun way to learn how to overcome fear. So each chapter explains a different game, and the participants can see how Miguel also plays the games. So after reading each chapter, the children must play the corresponding game, allowing them to improve their coping skills in tandem with Miguel's progress in the story. Some examples of the games are making shadows on the wall, for example, or searching a toy in a dark room. We found differences in nighttime fear between pre and post intervention. So specifically, when comparing the results of the experimental group before and after the treatment, significant differences were found in the subscale fear of nighttime features and distressing experiences, and in fear of imaginary stimuli. Also, we can see the evolution of the minutes to go to bed and to fall asleep as the intervention was applied. The minutes to go to bed were reduced from a score of 20 on the first day to 11 on the last day, and also the minutes to fall asleep went from 27 to 10, decreasing. When we interviewed the families after finishing the treatment, they indicated a decrease in fear and anxiety responses to darkness, saying that they see their children more relaxed when they go to sleep, and also they inform about an increased ability to control fear. For example, they say that children knew now when they have anxiety, or that children say that they lost the fear of the dark. So the main objective of the study was to analyze the efficacy of a bibliotherapy intervention in reducing children's fear of darkness, and findings demonstrated that the play-based bibliotherapy intervention has found positive results in children who participate in the study. These results are in line with the findings obtained by other authors who supported the bibliotherapy intervention reduce nighttime fears in children. And this study has some limitations as the sample size that should be bigger. We are now increasing the sample, collecting more information with more participants, and some variables that were not analyzed for this preliminary study, but the results in general confirm that reading a story combined with in vivo gradual exposure through games is an effective intervention method for children aged 4 to 8 years with fear of the dark. This treatment shows efficient, requires minimal contact with the therapist, allowing its adaptation to the characteristics and natural context of the child. So therefore, we also conclude that parents, through their involvement and support at a relevant age, has a very good job to help their children overcome the fear of the dark. So, grazie mille, thank you so much.
Yes, very nice. The children were normal children anyway, they are not clinical.
Yes, no, they only have a criteria, a diagnostic criteria of fear of the dark, but we didn't include other participants, other children with other.
So it is a normal development.
Yeah, normal developing, yes. Thank you.
That's one question.
Thank you so much. And
Thank you.
if you have any questions, we can.
Our last presentation is about the evaluation of parental experience and
Okay, do you hear me?
No.
Well?
No, here, yes.
Yes, I guess. You can hear me here, yes? From home? Let's double check. Just give me a signal of any kind.
Everybody's going to eat lunch, probably. Okay. So good to see you. Okay. Okay. So today we are going to talk. So we are going to talk about the Italian psychometric properties of the Italian version of a scale that has been developed in the US, measuring the experience of parents whose children have been through psychological assessment. The study has been done by us, but and here just our names because we are here to present, but the study was conducted with Anna Cavallini and Elisabetta Fioretti from the Hospital Dognocchi in Lombardia. And we are going to present together. Okay, so a little bit of introduction, and then we will move quickly to the results. The idea is that offering psychological services to clients often is accompanied by the worry of how are we doing it? How is our delivery system matching our clients' and customers' expectations? And generally, we do this by asking our customers what do they think about what we do. With children, this is not, with assessment of children, this is not possible, basically because children have a very limited vocabulary, most of the cases. And the parents are really the people that are involved in evaluating the services provided to children. To date, to assess the satisfaction for psychological services, the most used tool is the client satisfaction questionnaire, which has many merits. It's widely studied. It's a bulletproof, I would say, tool, but has also some disadvantages. First is that it's been used in assessing the quality of bank services. And one can use it also to assess psychological services, but probably being a customer of a bank and being a customer of a psychologist are kind of two different processes. And it's a monofactorial, so it only measures the general satisfaction. And probably we want to know more detailed information about what entails being a part of an assessment. The only other available instrument in the literature is the parent experience of assessment scale, which has been developed 8 years ago, around 8 years ago. It's a self-report test for parents that includes 24 items on a 5-point Likert scale, and includes different factors that are involved in the assessment. Basically, the scale measures these 5 factors, meaning the quality of the parent-assessor relationship and collaboration. For example, as a parent, I was informed about each step of the assessment. The new understanding of the child, for example, after the assessment, I had lots of new ideas about how to parent my child. The quality of the child relationship, assessor relationship. For example, my child felt comfortable with the assessor, the systemic awareness, like the assessment revealed how family members play a role in my child's problem, and the negative feelings for the assessment. The example, the assessment made me feel like a bad parent. In our study, we had 2 different goals. Basically, well, we have several goals. Basically, we used a quantitative and a qualitative part in our study. The quantitative part aimed at basically at assessing the psychometric structure of the scale. So basically the structure, the factorial structure, the ability, and the relationship between this scale and parental satisfaction. The qualitative part of the study wanted to deepen in whether this scale maps all possible, wanted to deepen in which are the experiences in the words of the parents behind responding to the questionnaire. And potentially this could lead to new insights that and to areas that are not or yet mapped in the scale. So basically what we did, we did a cross-sectional correlation study with 185 parents who completed the Italian version of this questionnaire and the client satisfaction questionnaire. We did a confirmatory factor analysis from back alpha and a structural equation modeling to predict parent satisfaction. And among those 155 parents who completed the questionnaire, 20 gave permission to be recontacted to have an in-depth qualitative interview. So it was a retrospective study. Basically, we did with these parents an extended inquiry, which is, I'm going to talk about it in a while, and we did a thematic analysis on the transcripts of the interviews. So what is an extended inquiry? Is basically a technique taken from clinical psychology, coming from collaborative assessment. It's an old technique which appeared 30 years ago. Basically, it involves asking two respondents of testing what is their experience at the testing while taking the test. Was it hard? Was it good? Was it strange? What did you notice about your responding? Is there anything that struck you about what you said, what you did while you were doing the test? And it's widely used in collaborative assessment and therapeutic assessment. It's less used in research, so this is the first time we have tried this approach. An example could be the assessor said in one interview, one more aspect that caught my interest is what you experienced during the evaluation. You responded not feeling judged, not feeling ashamed by reading the items. The only item you scored high was the evaluation made me feel like a bad parent, and that intrigued me because all the other scores in the negative feelings for the assessment were low. So I wanted to ask, why did you answer this way? And the parent says, oh, you know, because I allowed to happen many things that maybe I shouldn't have done. Things that have still marked my childhood. We are not talking about anything dramatic, maybe a poorly worded response or you can do anything, right? Those kinds of phrases that I might have realized earlier could have had an impact on my child. So basically, the idea is we tried to assess what is the rationale behind some kind of extreme responses, responding or contradictory responding in our parents. So now I pass the word.
Good morning. I'm going to present the sample now. Our sample was made of 185 participants, as said earlier, but our sample was also mostly made by mothers. 174 mothers, and on the other side, only 11 fathers. This could be intended on the other end as a thread to the internal validity of our study, but on the other end it points to the external validity. This because, as we all know, usually mothers are the most engaged parent in children issues. We administered the Queva G online and in paper form. The mostly participants did it online through a platform called Qualtrics. The children and of our sample were mostly between 4 and 11 years old, while the assessment requested to the instructors or to the questionnaire were mostly of a cognitive and neurodevelopmental type. We tested the fit of two models. The best fit was the one of this model, which is a first order model, where all the factors are supposed to be correlated factors with each other. Here are the fit indexes of this model, and the most significant correlations were those of Park, so the first factor presented by my professor, and respectively the relationship between the child and the assessor, the negative feelings, the new understanding of the child, and systemic awareness and negative feelings. Queva-G showed an excellent reliability, and also the subscales showed a high to excellent internal consistency. As you can see, its alpha is 0.91. Then we ran a person's correlation analysis between the Queva-G and the CSQ in 8 items. And we discovered that they have a high correlation. So we used the first model seen before, where all the factors are correlating with each other, in order to test their influence on the general satisfaction, which is given by CSQ, the CSQ. The circled numbers are the significant effects, which are the direct of Park and Nook on the general satisfaction.
Let's say the names.
I'm sorry. Parent and assessor relationship and collaboration influences most, impacts most on general satisfaction. In the second place, new understanding of the child on general satisfaction. The other factors didn't show significant effects.
Okay. Our thematic analysis has produced a comprehensive set of results, revealing multiple factors influence the experience, the parent experience of their child's assessment. Our results sorry. Our results show that they show dimensions that are investigated in Queva-G, but there are some themes that are not addressed by the scale. Our results consist of 3 main themes. The first one is parental perception of the assessment process. These results highlight that these results highlight that perceived relation skills okay. Yes, sorry. Okay. The results highlight the crucial role of the relationship between assessor and parents. In particular, our participants highlight a positive experience when they perceived the assessor as a competent figure who generally cared about helping them and their child. Also, feeling understood and respected by the assessor contributed to a positive experience. Then the therapeutic setting management is very important because in particular the level of involvement in the assessment process. The parental involvement in assessment process is very important because providing detailed information about the assessment process, its results, its tools, its phases, and also the future interventions is essential for parents. And although they are not addressed in the scale, the structural aspects of the assessment process influence the parent experience. In particular, parents express their frustration for the expensive cost of the private services and for the waiting list, for the turnover of clinical staff. Moreover, the coordination between services, in particular health services and school, is important because a collaborative effort can lead to a more integrated intervention for child. Then the second result is about the effects of assessment. We have two types of effects: the cognitive effects, such as the new understanding of the child, the achievement of a new understanding of the child, the achievement of a systemic awareness, and the learning of new parenting strategies. And these aspects are well addressed in our scale, but the second effect is concerned the emotional experience of parents, in particular the negative feelings are addressed in our scale. The sense of shame, the sense of blaming, but the QEVA-G doesn't map the positive feelings, like the relief for a good explanation of their child's diagnosis, for example. And the third result is the parental perception of the relationship with the children's teacher. Why? Because it is not included in a assessment process. So we understood that parents expressed a more positive view of assessment process if teachers demonstrate a genuine interest in assessing their child, and providing a personalized attention for the child educational needs. Okay.
Okay. Thank you. Okay, so basically the idea without the conclusions, everything. Meaning? The time? Okay. Come siamo messi?
Okay. Oh, right.
We have time? Okay, thank you. 5 minutes, okay. We will. Yeah, I look at her. Okay, so you are in charge. Okay. So, basically, the take-home messages, psychometrically it works. So Italian assessors who work with parents, it's available. It's published on an open access journal. So just Google it, download it, and use it with your clients. Clearly, assessors should pay a lot of attention in the building phase of building the relation phase with their clients, and but this is not enough. Probably we also need to teach something new to parents about their children. What is new, we think, is what Sarah was mentioning earlier on, meaning that if we think about this in this way, think about the change from an intrapsychic model of assessment in which you assess the child mind. Then you move to an interpersonal model of assessment in which you assess the child within its family. And we are here now. What the qualitative study says is that we need to widen, even broader the focus. We need to engage all other services. The assessment has to engage the teachers, has to engage educators, has to engage other relevant figures. Otherwise, parents experience that the assessor is missing its goals of helping the child. So it's really a call to become more systemic and more probably contextual in our work. 1 minute. The pros, we already said it. And the limits are here. Okay, I think we don't need to spend too much time about this. We already mentioned the fact that yes, mostly mothers responded, but it's unfortunately the way it works in our system, in which mothers are mainly the people that talk with parents, talk with teachers, talk with psychologists, and so it's.
I don't have it.
No, you don't. Good for you. No, I do my best to help with my children, but it's an effort in our society. So, okay. So, thank you for your attention.
I'd like to summarize a little bit what happened this problem. Yeah. And sometimes my colleague said to me that a bambinologist, what I mean, that maybe I too much interest in children, okay, but the thing what happened in this presentation, I think that really we know, but we don't know enough anyway about normal children, about development, and how many studies we need to do more about what is happening, okay? So, beginning from the first frustration study, it's a very old,
Can we go?
Sorry.
Can we go?
It's okay?
Can we go? You're good? Okay.
Sto concludendo.
So if you have any questions,
Riprendo un po', okay? So I said that the frustration, projecting method is very old. It never got really a very nice scoring, but it is very useful if you look to frustration in children. And really, we don't know so much about that, but also how much you need a new kind of scoring that is more connected with an operational way to meet, a new maybe ways of understanding. Then I go to the Professor Spaza, and I want to tell you what happened this year when I was to the exam of state of psychologists in Italy, and when there were people working about children, most of them were about learning disorder and changes about learning disorder. When I asked them, but there were no children without anxiety, there was no children about depression, the answer was, we are not interested in that. So this is very, very sad, because as you illustrate with your network, children are facing many self-concept problems about anxiety, about depression, and also you underline about, social worries, because social worries are very important for elementary children when they need to task, to cross task at school, socially, and so on. Then, you know, another really interesting thing is that this presence scale is very known, you know, we get also validation of the scale. It is interesting that it was not, so much validated with the clinical children. So it's very important because we used, play everywhere in our assessment, but there are no researches about that. Okay. And about the dark in children, it is so nice, because this is a very, on one hand, a very normal problem. But if you don't do work with normal children about that, the fear is that it becomes something that is more deeper and that it goes to, some phobias or something. And it is very important for parents that you can go to the normality or between, and then this very nice intervention where parents can be very happy. Maybe you need to know more about their feeling, how you evaluate that, okay? And then to the, where is our, finito, okay. I think that it is very important to, evaluate how much parents are enjoying or judging or saying what is about assessment of their children. We don't need so much, but really, again, we need to experience. So I think that maybe this altogether is about question more than answer, but it is very important to continue to work about that. Thank you very much to everyone.